Reflexes. The deep tendon reflexes requires the stimulus, sensory pathway, motor neuron, contracting muscle, and the synapses between the neurons in order to elicit a response. Okay, so reflexes. What we need to elicit a reflex? We need the stimulus. The sensory pathway must be intact, motor neuron, and a contracting muscle, and the synapses between the neurons in order to elicit a response. So now we come first to causes of reduced or absent tendon reflex. This may occur due to any breach in reflex arc. For example, the sensory nerve that may be affected in the case of polyneuritis, the sensory root in the condition of tabes dorsalis, for example. Third, the anterior horn cells in case of poliomyelitis, and the anterior root in case of there is something compressing the anterior root, and the peripheral motor nerve in case of trauma, and muscle in case of myopathy. So the reduced or absent tendon reflex, this may occur due to any breach in the reflex arc, in the sensory nerve, sensory root, anterior horn cell, anterior root compression, peripheral nerve, and muscle. Okay, poliomyelitis in sensory nerve, tabes dorsalis in sensory root, poliomyelitis affecting the anterior horn cell, or a compression affecting the anterior root, or peripheral motor nerve damaged by a trauma, or a muscle that is not working or well because of myopathy. Okay, now we come to the topic of increased deep tendon reflexes. Due to lesions of pyramidal system, increased deep tendon reflexes may be excessively prolonged, with a larger amplitude in cerebellar lesions. In myxedema, the relaxation phase of reflex is retarded. First paragraph. Due to lesions, the increased deep tendon reflexes occurs due to lesions of the pyramidal system, and increased deep tendon reflexes may be excessively prolonged, with a larger amplitude in cerebellar lesions. In myxedema, the condition that occurs in the case of hypothyroidism, the relaxation phase of the reflex is retarded. Each deep tendon reflex is associated with a particular segmental innervation and peripheral nerve as listed in table 1.3. Okay, when we come to table 1.3, deep tendon reflexes, peripheral nerve, and segmental innervation. For example, our first one in the biceps jerk, the major segmental innervation is C5, C6. Okay, the peripheral nerve that is responsible for the for eliciting the reflex is the musculocutaneous nerve. In the supinator jerk, C5, C6, the radial nerve. In the triceps jerk, major segmental innervation, C7, C8, the radial nerve. In the flexor finger jerk, C6 to T1, the median and ulnar nerves. In the knee jerk, L3 and L4, femoral nerve. And the ankle jerk, medial popliteal and sciatic nerve. Each deep tendon reflex is associated with a particular segmental innervation, as we discussed in the table, and peripheral nerve. The superficial abdominal reflex has a segmental innervation extending from T9 in the upper abdominal region to T12 in the lower area. The reflex may be absent in pyramidal lesions above the level of segmental innervation, particularly in spinal lesions. However, the reflex may also be difficult to elicit when the abdominal muscles have been stretched or damaged by surgical operations, or in a large pendulous obese abdomen. Okay, we repeat this paragraph. The superficial abdominal reflex has a segmental innervation extending from T9 to T12 in the T9 in the upper abdominal region to the T12 in the lower area. The reflex may be absent in pyramidal lesions above the level of the segmental innervation, particularly in spinal lesions. However, the reflex may also be difficult to elicit when the abdominal muscles have been stretched or damaged by a surgical operation, or in large pendulous obese abdomen. Plantar reflex. This could result in the great toe flexing metatarsophalangeal joint. The Babinski response consists of extension of great toe at the metatarsophalangeal joint, and usually at the interphalangeal joint, and indicates a disturbance of the pyramidal tract. Thank you very much.